All right. So we're going to get started, and good morning to everyone who's here in person, as well as those who are joining online through Zoom. It's my pleasure to introduce our speaker today, Dr. Kristina Joyal. I'll begin with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land, which is a very good segue into what we're about to hear. Dr. Joyal will be speaking. She's a pediatric neuromuscular neurologist. She grew up in rural Manitoba, earned her BSc in neuroscience at McGill University, and then completed medical school at the University of Manitoba. From there, Dr. Joyal completed a pediatric neurology residency. Thank you very much. That's all right. Completed a pediatric neurology residency here with us at CHEO. And she now provides pediatric neuromuscular care for Manitoba, Saskatchewan, and if that's not enough, the Kivalliq region of Nunavut. She also does outreach pediatric neurology clinics in northern Manitoba and in Nunavut. She is passionate about improving care to patients with neuromuscular diseases and those in the Canadian North. And in her free time, she likes to hang out with her family, read, cycle, and attend metal shows. So I'll turn the podium over to you, Dr. Joyal, and thank you again for coming to speak.
Thanks for having me, everybody. It's great to be back. As Hugh had mentioned, I was a resident here from 2015 to 2020. And I'm very excited to talk about this long labor of love. Head circumference values in Inuit children are larger than WHO references. How do I get the slides to advance? The arrows weren't working. Enter.
Clicking screen. I'll try it now. There you go.
Okay, there we go. And so this project was just published in CMHJ in October, but I'll give you guys a brief update about how this project came to be. So I decided that I had wanted to come to CHEO because the pediatric neurology program had outreach clinics to Inuit, and that was something that I knew I wanted to do. And so as a resident, I was very fortunate to be able to go up a few times with Dr. Vakiteshwaran, who has joined us here today. And from there, further confirmed my interest in caring for patients from the North, Indigenous patients. And so one of the project ideas that had come up was that Inuit children seem to have larger head sizes. And within neurology, we often see children with head circumferences that are at the extremes. Either they're microcephalic or they're macrocephalic, and that often comes with neurologic pathology. And we were noticing that children with neurologic conditions weren't always showing microcephaly, these Inuit children, I should say, and many children had macrocephaly. Anyway, so this project kind of came about after a few trips, and then it expanded from there. So what started with basically me and Dr. Vakiteshwaran expanded to this large team at CHEO. We had a local pediatrician, Dr. Amber Miners, and she connected me with a group at University of BC at Victoria, Dr. Laura Arbour, and that group had already had very strong connections with several groups in Nunavut, including the Government Nunavut Department of Health, the Nunavut Tungavik Incorporated, as well as the QHRC, the Hawiakit Health Research Center in Nunavut. And so what started as a very small project kind of locally at CHEO, maybe at Iqaluit, doing some just brand new, we were starting the project. I ended up getting connected with that group at BC, and they had this massive data set of information about the health of Inuit children in Nunavut. And so we were very fortunate to be able to combine our projects with them, and it turned out much larger than I could have even hoped as a small resident research project. And now, as I mentioned, been published in CMAJ. The government of Nunavut is very excited about this project and incorporating it into future clinical use. And we've presented this project at a few different conferences already. The 18th International Congress on Circumpolar Health, which is like all the northern countries around the world, so Greenland, Finland, Norway, Alaska. It was presented at the International Meeting on Indigenous Child Health, and I'll also be talking about it at the Canadian Neurological Conference later this year, and even did interviews with Radio-Canada en français and CBC North. So what is this project that I'm really excited about? So if you work in a children's hospital, I'm going to assume that you know what a growth chart is. I'm gonna take that for granted at this point. So as I mentioned, it kind of all started as a small little resident research project that we were seeing Inuit children having macrocephaly without clear disease, and kids with known neurologic conditions that usually have microcephaly were having normal head circumference when being plotted on the WHO. And when we reviewed the literature, there were many other populations that noticed a similar pattern, that the head circumferences really didn't seem to, the WHO growth charts didn't really seem to reflect the local populations. Notably for Canada, this had been published already for the Cree population in northern Quebec, and then as well children in Greenland, which are often Inuit. And then this may lead to error in recognizing microcephaly and macrocephaly. And what does that mean as a clinician? I'll talk on that at the end. So as I mentioned, we had joined with a group from UBC, and they had done a larger study that had been focusing on CPT1A variants. If you see neutral, you might know what that is. In any case, they had already had this huge data set of medical charts that had been reviewed for Inuit children. So this group, they were born between 2010 and 2013. They had to reside in Nunavut. They had to have at least one parent who was Inuk, and their charts were reviewed from birth to age 5 years. And as I mentioned before as well, this had been done in strong partnership collaboration from the very beginning with 3 different local Nunavut and Inuit groups, the NTI, QHRC, and the government of Nunavut. And so they had this large data set, and so then what we were focusing on was neurologically, genetically healthy children. So we excluded those with preterm birth, we excluded those with neurologic and genetic conditions, and most congenital anomalies. And so these were, as I mentioned, neurologically healthy, but we didn't exclude, kids that had asthma or recurrent, like other health issues. And so from an initial total of 2,522 charts, we ended up analyzing 1,956. And then the complicated statistical part, I'm not a statistician, but the medians at the middle of the time point intervals. So we're looking at the head circumference, different age time points, and then to compare, we took the middle time points of those intervals to compare to the WHO. So for example, 0 to 2 months, we compared at 1 month for the aggregate of 0 to 2 months. And compared to WHO. And then we compared the Z scores from the Inuit head circumference data to the WHO reference using Centel's estimated generalized additive model. And then we also looked at macrocephaly and microcephaly and compared the proportions of children who would be diagnosed with macro and microcephaly using an Inuit specific chart versus WHO standards. So we had a total of 8,789 data points, which when you consider how small the Inuit population in Canada is, that's actually a very large number of data points. The median head circumferences in the study cohort, so the Inuit children, were significantly different, larger than the WHO reference at all time points for both males and females. In terms of absolute values, at birth, the difference was 0.5 and 0.6 centimeters for males and females. And the maximum absolute difference in head circumference, median head circumference, was 1.9 and 2 centimeters. And visually, I think this picture, this growth chart really summarizes the results in the best way. So the black dashed lines are the WHO head circumference growth chart references. Can you see? Yes, okay. So the middle line there is the 50th percentile by WHO. The bottom line here is the 3rd percentile, and below this 3rd percentile is when children would be diagnosed with microcephaly. And then this black line here is the 97th percentile by WHO. And so children above this line, or head circumferences plotting above this line, would be diagnosed as macrocephalic. All the gray dots are data points from the Inuit children. And the colored lines, so this green line here, sorry, this pointer is a little bit tricky. The green line is the 50th percentile when using Inuit specific data from our study. And so you can see that the 50th percentile line is actually closer to the WHO 97th percentile line than it is the WHO 50th percentile line. The 97th percentile line is much higher, and the 3rd percentile line is somewhat higher than the WHO 3rd percentile line. And so this shows how the median, so the 50th percentile head circumference, is much larger than the WHO reference. And there are many children, so all these gray dots here, who are being diagnosed with macrocephaly by WHO, where it might actually just be normal for their ancestry. And then on the other side here, there's between the blue line, which is the 3rd percentile for the Inuit, and this black dash line, the 3rd percentile for the WHO, there are these children here, these dots here, who may actually be microcephalic, are considered normal because, again, their overall average head size is larger. Looked at in a different way, the Z scores for the head circumference were all 0.5 to 1 standard deviation above the WHO reference. And so the WHO reference would be at this blue line at 0. The lines for each of these bars is the 50th percentile, and the range of the boxes is the 75th to 25th percentile. And so again, it's showing in another way that the medians are much higher than WHO. And then when we looked at microcephaly and macrocephaly, so for microcephaly, there were 1 to 2 fewer cases of microcephaly being diagnosed if WHO is used compared to the Inuit specific information. And for macrocephaly, there was a bit of a difference for males and females, but for males, 25 to 30% more cases of macrocephaly, and for females, 15 to 20% more cases of macrocephaly being diagnosed with WHO than if using a population-specific chart. In terms, thanks, Ayla, that's my daughter back there. In terms of absolute numbers, so of our total cohort of 1,956, for macrocephaly, there would be 245 patients where they both agreed, yes, this is larger than the 97th percentile. There would be 651 children who would be diagnosed with macrocephaly by WHO, but they would not if they were using a population specific. So that's a lot of children. And we'll talk in a little bit just about like what does a diagnosis of macrocephaly mean for these children. For microcephaly, there would be 145 where both charts agreed, and then 79 cases where they are essentially being missed or underdiagnosed with microcephaly. It's not being caught by WHO. This 4 that would be diagnosed with microcephaly using WHO but not Inuit, that's a bit of a weird outlier. There was one specific time point where the WHO 3rd percentile was actually like 0.1 centimeter higher than the Inuit at one time point, but then for the rest of the time points, the WHO had a smaller 3rd percentile. So in a few different ways, we showed that Inuit children in Nunavut have head circumferences that are larger than expected compared to WHO standards. And so us as clinicians need to know that there's going to be 20 to 30% of Inuit children that may be diagnosed with macrocephaly. Just in our cohort, 641. And so what does this overdiagnosis mean? So Inuit children, they live primarily in Nunavut. Our study focused on children from Nunavut. This is very far away from Ottawa, where we are right now. And Nunavut is divided into 3 regions, but the eastern part of Nunavut tends to be sent down to Ottawa if further investigations are required. The middle section, the Kivalliq, is sent down to Manitoba, where I work now. And then the western part will often go to Northwest Territories. So these children even from Iqaluit, but Pang, Clyde River, Pond, all these places that you guys have seen patients from, if it looks like they have macrocephaly, and in these locations, it's often public health nurses that are doing the well child visits with family doctors that come in sometimes, pediatricians that come in more rarely. And so a public health nurse will see, okay, this child is macrocephalic and refer for further investigations. To come down from Pond Inlet to even Iqaluit is a flight that often has weather delays. And then many children are also referred to be evaluated by a specialist, neurology or neurosurgery often, and may get imaging, so CT scan or MRI. And so that usually requires going all the way down to the south, Ottawa or Winnipeg or wherever. And that's a huge trip. So I've gone up there, and I've been weathered up there, so I have a better appreciation for what that means, but it's multi-day travel. So a parent or caregiver has to come with the child, 1 or 2 flights that are several hours long. They have to take several days off work. They have to arrange childcare for their other children. They have to come down to a place where they're not familiar with the culture or the language, all to be told your kid's fine. So this is why we feel it's, yes, it's like a tangible difference, but it has real implications for these children and their families about why we need to be using appropriate growth charts for them. For the reverse, microcephaly being underdiagnosed, as neurologists, we've seen the cases where children have neurologic conditions that are associated with microcephaly, but the Inuit children aren't microcephalic, and that can sometimes cloud the diagnostic picture because we all look for patterns, and microcephaly is often one of those features that we put into our list. And when I was presenting this at the International Congress on Circumpolar Health, I actually met the parents of the child who was the first child in Canada diagnosed with Prune 1 syndrome. Prune 1 is a genetic severe condition that affects primarily 3 First Nations children. And initially, he had been evaluated on a research basis, and the diagnosis of prune 1 had come up on the research basis, but he wasn't microcephalic, and so it was kind of dismissed initially. And this is what the parents said, like independent of even like this presentation. They were presenting and said that the diagnosis of prune 1 had been missed for their child initially because he was not microcephalic. And then later on, he did end up being diagnosed with it, but it completely highlighted why underdiagnosing microcephaly in Inuit, and I'll talk about how there's a similar pattern in First Nations children as well, does make it harder to come to the right clinical diagnosis at times and can delay appropriate medical treatment for these children. As mentioned, the Inuit population are not unique, so notably in Canada, First Nations are also seem to have a similar pattern. And then worldwide, there have been other populations as well. So what are the next steps? So I have been collaborating with the government of Nunavut Department of Public Health to use these growth charts. So the data that was able to create a growth chart where we compared to WHO, we took that information kind of separately so we can make a brand new growth chart for Inuit children. And so I have made these growth charts, and they are planning to include them as an appendix in the next Nunavut Well Child Guideline. And so this will hopefully be ready starting in June of this year. And then it'll also be available online. And so what we're recommending in terms of how to use this going forward, for now, it's Inuit children from Nunavut because that's what our study population included. And so still using the standard WHO growth charts. But if these children are showing a head circumference that's less than the 25th percentile or greater than the 97th percentile, it should be plotted on these Inuit specific head circumference growth charts to get a bit more population specific information. Of course, this is all in the clinical context of a patient. We never use head circumference in isolation. If an Inuit child is above the 97th percentile and that they've been plotting along their curve, we're not worried. If their head circumference is growing exponentially and now it's above the 97th percentile, we're not going to ignore that. It's still in the clinical context. But this is an additional tool to kind of see what the population specific kind of true head circumference may be. And in clinical practice, then I kind of do this in my mind already. Oh, their head circumference above the 97th percentile, but they look fine. Okay, I'm really not that worried. Or they have a head circumference that's at the 5th percentile, but they have all these other neurologic concerns. Then I'll kind of put in my notes that this looks like a relative microcephaly, because in my mind, I think they may have microcephaly. I can't prove it because it's not less than the 3rd percentile, but it would fit with the overall neurologic clinical picture. And then other future projects that need to be done is confirming a similar pattern in Inuit children elsewhere in Canada. So at the Circumpolar Conference, then I was meeting with people from Northwest Territories, and they are interested in also using this, a similar Inuit specific growth chart, but we do, we should prove that it's the same case for Inuit children across Canada. It likely is based on clinical experience, but if we're going to do something as big as introducing an additional growth chart, we should probably prove that first. And as I mentioned, there's a similar clinical pattern seen in First Nations children. And so I have joined a pilot project that is currently underway in Saskatchewan that's looking at the same thing. And hopefully it'll get to the point where we can also develop a growth chart to be used in addition for the First Nations children. That is a bit more complicated because there are so many different subgroups of like Cree and Ojibwe and Dene and Anishinaabe. So it would be a bigger project for sure, but for now we're looking at it in Saskatchewan. And then pictures of 2 of the reasons why it took so long to get this project done. Well, that is all I had.
And we'll open the floor for questions.